My name is Abigail Kramer. I am an editor at the Center for New York City Affairs at the New School, and I head up our work on children's behavioral health reform. I am really excited about this event, and judging from the wait list, a whole lot of other people were too. We are being live streamed because there were a bunch of people who wanted to be in the room and couldn't make it in, so you're elite. One thing that I really appreciated in looking at the RSVP list, the people who signed up, is that not only do we have a lot of people here who are from behavioral health organizations and whose work is directly impacted by the things we're going to be talking about, but there are also a lot of people who work with kids in other arenas, like schools and child welfare and juvenile justice and community organizations. And I think that's not only a real testament to how dedicated folks in this town are who work with kids, but also a win for the mission of creating a broader understanding and advocacy for good children's behavioral health care, and of really pushing it to be integrated into communities and the places where kids and families are and the people who they trust. So that was a great thing. Also, a win is this panel. We have a really deep bench of remarkably smart and interesting people who are deeply committed to the work that they do. And are here to talk about this moment of change and opportunity for children's behavioral health care. I think that it is a moment for real optimism. There is an unprecedented recognition of the importance of behavioral health, not only in individual lives and the health of communities, but also to the sustainability of the healthcare system overall. We are having mainstream policy conversations with dollars attached to the impact of trauma in early childhood. And to a lesser extent, we're having those conversations about the trauma caused by institutional violence against youth of color. We have a Medicaid redesign process in which the state has committed resources to expanding services, to expanding access, to giving providers the flexibility to meet families in their communities. There are also obviously major challenges. There are significant gaps in the system, chronic underfunding of clinical services, insufficient attention to the needs and strengths of our most politically marginalized communities. So we are here to talk about what the behavioral health care system we want looks like, and what we're doing to get there, and the obstacles that are surely in the way. Let's get right to it. I will take a second to thank the supporters who make this work possible, including the Altman Foundation, the Child Welfare Fund, the Cyrus Fund, and the Ira W. DeCamp Foundation. I also want to thank Camille Vargas and the events team who do all the logistical wrangling that gets us into this room. It's a lot of work. And I want to thank our panelists who have educated me, in some cases over the course of months, and in some cases in crash courses over the last couple of weeks. I will let you guys introduce yourselves, take a moment to say who you are, what you do, and the expertise you bring to this conversation. I'm thinking let's start down at the end with Marnie, and then if we work our way this way, we will land on you, Donna, and you can launch straight into an update on what's happening with Medicaid redesign.
Fantastic. This is on. There we go. Thanks. Thank you so much, Abigail, for having me today. My name is Marnie Davidoff. I am the Assistant Commissioner for the Bureau of Children, Youth, and Families. That is a bureau within the Division of Mental Hygiene at the New York City Department of Health and Mental Hygiene.
My name is Kenton Kirby. I am the Director of Clinical and Trauma Support Services at the Crown Heights Community Mediation Center, which is a project of the Center for Court Innovation. Good morning.
Good morning. My name is Tonya Spence. I work at the Jewish Board. I am the head of Early Childhood Services. So that means I oversee clinical, early childhood mental health consultation, and our special education services for early childhood. Thank you for having me.
I'm Gail Nayowith. I am the principal of One Digit LLC, which is a project management and consulting practice. I'm the former co-chair of the Children's Medicaid Redesign team. Sit on the Board of Health and chair the Community Services Board for the New York City Department of Health and Mental Hygiene.
I'm Jennifer Havens. I'm the chief of child psychiatry at Bellevue Hospital and the vice chair for public psychiatry at the NYU Department of Child and Adolescent Psychiatry. I oversee the clinical services at Bellevue Hospital as well as contracted services in secure juvenile detention and the Children's Center with New York City ACS.
Good morning. I'm Donna Bradbury. I serve as the Associate Commissioner for the Children's Division at the New York State Office of Mental Health. So I'll get started.
Go for it. Break the news.
So I love that it's a mixed audience. Of course, most of the time when I'm talking to audiences, it's a mental health audience, and it's really a pleasure to hear that there are schools and juvenile justice and child welfare represented here today, because I come from a foundation of cross-systems work. So before I started working for the Office of Mental Health, I worked for a relatively rural county, upstate New York, for the mental health department. And that was when the Coordinated Children's Services Initiative was just getting off the ground. So just curious, a show of hands, anybody, does that ring a bell to anybody? CCSI? A little bit. Okay, good. So that was the state's first real foray into real cross-systems work with real money behind it and real policy that backed up that work. And it just sheer luck that I landed in that county when that was getting off the ground. And it gave me such an important foundation for the work that I'm doing now, and such insight into the reality that we all really need to work together. It's more than just a sort of a cliche. It's really fact that we, as systems and as individuals, need to work together to serve children, and particularly now when we're in this era of extremely tight budgets and just more stress, I think, on our collective systems than ever. We really need to pull together. So thank you all for your interest and for being here. So in planning my remarks, Abigail and I talked about the fact that a lot of you are from outside of sort of behavioral health, that it would be worth sort of doing a little bit of a history lesson on how we got to where we are now with the kids' Medicaid managed care design. So this design has been 7 years really in the making. So about 7 years ago was when all of the Medicaid redesign teams for New York State got off the ground, and they were addressing lots of things in addition to behavioral health. But there was and is a behavioral health Medicaid redesign team, and very early on in the work of that team, people collectively realized that if we're going to talk about moving children's behavioral health into Medicaid managed care, we need a team just focused on that, because kids' needs, as we know, are so unique and very different from adults. And so the Children's Medicaid Redesign team was created, and I'm co-chair on that Medicaid Redesign team, and for a long time, Gail was my co-chair. And I've been on that team for 6 years, and for that 6 years, we've been very focused on what is going to be the benefit package, right? So, and everybody was very, well, I shouldn't say everybody, but a lot of people were very worried, right, about this transition to managed care, because generally the thinking is when you think about managed care, you think, right, about potential losses, right? You think about a constricting of access and a constricting of availability potentially. And so coming from the kids' world, the kids' mental health world, where we've struggled forever with having enough, right? Having enough resources, having enough funding. We were very worried about this concept of having less. And so we did what in hindsight was an extremely smart and critical thing, which was we simply changed our viewpoint or our perspective from one of sort of we got to hold on and not lose anything to wait a minute. This transition to Medicaid managed care gives us a unique opportunity to make real reforms in the children's behavioral health system. So that perspective change I think made all the difference. Because then we started to look for technical pieces of the transition that could actually give us opportunity. And indeed, it turns out there's lots of opportunity. And so when we sat down, with consultants, we started to figure out that the technical pieces of making this transition gives us all kinds of opportunity to make additions really to the system, to make changes that we've longed for but didn't really know were possible or didn't know how to do it. And so, at this point, when I'm saying we, it's really a cross-agency state team that includes child welfare, includes substance abuse folks, includes the Department of Health, of course. The Department of Health is a critical player, really a key player, because the Department of Health is our Medicaid authority. So they're really the centerpiece to this. So you've got several child-serving state agencies at the table thinking collectively about how do we make improvements in our system. And so we started just by taking inventory. What do we have, right? So, we kind of have a list of state plan services. So I promise I won't get too wonky on you, but it is worth explaining a little bit of this technical stuff just to have an understanding. And to those of you who have been following this closely, I apologize. You can tune out for a few minutes,
You can't hear it too many times.
You can't hear it too many. Thank you, Gail. So that's true. So state plan services in the Medicaid world, that means that these are services that if you are Medicaid eligible and you meet basic medical necessity criteria, you can access those services. So if you need it, you can get it. So think about a mental health clinic. That's a state plan service. So if you have a mental health diagnosis and you need treatment, you can access that service. So we have we have an array of those services. We also have what are called 1915C home and community-based services, right? Or in the OMH world, people call it the OMH SED waiver. There's also a Bridges to Health waiver that belongs to the child welfare world. There's also a medically fragile waiver. There's also a waiver for medically fragile kids who have developmental disabilities in the OPW world, right? So we have all these waivers that allow us the flexibility to deliver support services to families that help kids stay out of residential treatment facilities or residential placement of any kind, really, or hospitals or nursing homes if they're, these really medically fragile kids. So those waivers are designed to funnel Medicaid dollars to these support services for the purpose of keeping kids out of placement where we know they shouldn't be. Right? They shouldn't be unless they really have an acute need to be in those places. And so we know that those waivers work, and they work well. So when we took inventory of the system and we said we want to preserve all those state plan services and we want to preserve all those home and community-based services, but there are problems. First of all, there's just generally not enough, right? And I don't need to tell you guys that because a lot of you guys struggle with that probably on a daily basis. There's not enough. But almost more importantly, there's these sort of systemic barriers. There's these, by definition, the home and community-based waivers belong to certain worlds. So you can't get into the Bridges to Health waiver if you're not in foster care. You can't access the OMH waiver unless you have serious emotional disturbance. And so we've long thought that it would be great if kids who have a functional need, who have a functional impairment, who need those services, could access them regardless of kind of what door they came through. We've also recognized, at least speaking from the OMH world, that when kids are served in our waiver, they do very well, and then guess what? We discharge them, right? And then all they have available to them are state plan services, and sometimes, frankly, they don't even have that because the waivers allow for something that we refer to easily as deeming, but it means a child is considered a family of one and their parents' income is discounted so that if they're covered by commercial insurance, they can actually become Medicaid eligible so that they can access the waiver services. And when they're discharged from the waiver, eventually that goes away. And so then those kids have only what they can access through their commercial insurance, which is sometimes very little to nothing. So we've long recognized this need to sort of have a step down from our waiver. So you know, as we were identifying these needs in these gap areas, we started to use the tools that were available to us as we were planning this Medicaid transition to fill those gaps, right? So what we landed on in our design is really, I like to describe the package in two parts. The one part is an expansion of state plan services. So remember those services that are easy to access, that all you need is Medicaid eligibility and meet medical necessity. So we designed a set of 6 state plan services. Some of those services, interestingly, are in today's world home and community-based services, because CMS, Center for Medicaid and Medicare Services, which are the, you know, has all the rules that we need to follow in terms of how this stuff gets designed and implemented. CMS says, we want you to deliver these services earlier. Don't wait until kids have a functional impairment, that functional impairment that they need to access the home and community-based services. Don't wait too long, because we know in kids' mental health, if you wait too long to intervene, even the best interventions have a really hard time of having an impact, right? And so CMS says you should be not delivering these in a waiver where kids have to have a functional impairment. They should be delivered sooner in a child's trajectory. So there's these 6 plan services, which I won't get into unless there are questions about this. And then there are what we're doing with the home and community-based services is we're taking those siloed waivers and we're saying, let's get rid of those barriers that are systemic barriers and just make one big array of home and community-based services. So it doesn't matter what door you come through. If you have a functional impairment, and that has to be measured through an instrument, right? The CANS instrument. If you have a functional impairment, you can access these services. So the package is really those 2 parts, those state plan services and those home and community-based services. Now, if you've been paying attention to this, you know that because it's an expansion and it's more services, it requires an investment up front, right? And we've had commitment all along from every part of state government that this should be done and it should be invested in. We had, as most people know, a very, very rough budget year this year, and there was some anxiety, I should say, some degree of anxiety that our implementation that we were planning for later this year might not be able to happen. So what we've just found out with the passage of the budget is that this transition will begin this budget year. We're looking at beginning the transition in January of 2019. And I don't want to take up too much time, so I can talk, I can answer questions a little bit about the details of that, but I do want to just make it clear that this transition will begin in January 2019, and then there will be sort of an incremental rollout of the design over a span of years. So I'm going to pause there, and I don't know if you wanted to.
Great. Well, I think we should
now
open it up to the panel a little bit, and we will have a dedicated time for questions at the end of the conversation. I do want to jump to Gail for a moment, though, because Gail, you were also in a leadership role in designing this package, and then fought like hell when it looked like the funding wasn't going to be there at the beginning of the year. And I would love to hear your take on where we're at now, what's happening, what's missing, and what you think the potential pitfalls might be moving forward.
Okay, great. Thanks, Donna. So I co-chaired with Donna. I did a year longer in my stint than she did from the beginning of the Medicaid redesign. But, the plan really was to figure out how to make sure that the Medicaid system would be responsive to kids. And overall, as a policy issue, a policy advocacy issue, it's critical because if you don't make the Medicaid system responsive to the needs of kids with behavioral health needs, medically fragile kids, kids in foster care, there is no entitlement for service. And we stand in line every year on the State House steps and we beg for money with a bucket and we do whatever we do and we try to get money for little programs and it doesn't really scale. So the idea of the Medicaid redesign was, as Donna said, to try to create a more coherent way of looking at services overall to reduce the barriers at the front door and to make sure that the services were available when, where, and how kids and families need them. So that was really the goal. You know, the challenge was that in the governor's budget release in January, February, the kids' Medicaid redesign was basically put on a 2-year delay. So it seemed to me that a 2-year delay after 7 years of planning was really beyond the pale. And so I resigned publicly in a strongly worded letter to the governor suggesting that it was time to fund these services and honor the commitment that's been made. And so fast forward, Abigail did a lovely article. I don't know if you guys saw it. Is Cuomo ditching the kids' Medicaid, I don't know, redesign? I don't know. I can't remember the titles of everything. Dan Goldberg at Politico did 4 articles. The advocacy community mobilized. The provider community mobilized. People went to Albany. And we got $15 million in the budget, which is going to be matched by $15 million in federal funds, God willing. And we did it through the Medicaid redesign, which is a critical piece. So I know that many people, and I don't know, you all look way younger than me, except for the ones I know that are older, but I won't mention you. But you guys don't, you know, you don't have a memory of having only hospitals or having only residential placements. And that's not good. It wasn't good enough. And through all thick and thin and special grants and whatever it is, we managed in the state of New York to cobble together some system of care for kids. And we're not going back to that. It's too fragmented. It's too much of a puzzle. The money's too erratic, too irregular, and it requires too much fighting. So these kids who are covered by Medicaid have a right to an array of services as defined in the state Medicaid plan. And so the entitlement, the Medicaid plan, becomes a very critical policy document for us. So it was important to put the money back so we could have these services. I guess I also want to say that, you know, budgets are only a starting point. I've been a kids advocate for 30-something years. So budgets are a starting point. It's never the end point, and it should never be the end point. And so, you know, you go in and stuff falls off the table, and then there's a little bit of horse trading, and there's politics, and the way we got this money back was because the governor and the legislature agreed to fund it. And so that speaks to the power of the need for kids, and it speaks to the power of the understanding of the legislature and the governor's office of how important this really was. You can't really do Medicaid redesign in the state of New York and not cover children in this way. It's not possible. It kicks the problems down the road. It creates all the conditions that you don't want, which is emergency room use and chronic health conditions and horrible impact of trauma and so forth and so on. So anyway, the money's back. So we're very happy about that. We're hoping that the services start mid-year, January. It gives a lot of time to, you know, plan and roll forward. And there are a couple things that we need to see. One is we got 3 of 6 spa services, right? I think we got 3 of 6. The rehab package, a little clinical, a lot of restorative. It's good. We want those services to run through the health homes as planned. The health homes were not part of the original design, but they exist. And they need to do more than just care management and care coordination. There have to be actual services that families and kids can access. So we would like to see the other 3 of the 6 services come online. We want to see them run through the health homes. And we want the 1115 waiver approved by CMS and funded by the state of New York. Because that package will give kids forever access to these services unless unless somebody in Washington obliterates the Medicaid program, which, you know, I never thought I would live to say, but it could happen. But we're not going there. Yeah, we just are not going there. So it is so important, really, now to focus on the implementation and for yourselves, trying to make sure that wherever you are affiliated, whether you're in a health home, whether you're a provider, standalone, whether you're in a network with a managed care company, whether you're running a health home or you're in the health home provider network, that you understand what the services are and you enroll as many kids as possible into these services, and you produce good results. That's part of the challenge now, is to really make them work and to make sure as many kids as possible come in through that front door. Because the more demand there is, the more ability we have to negotiate for the next 3 services and for the 11-15. So, I mean, that's really, you know, that's basically my view. I mean, there's a whole blood and guts story here, too, which we can get to at some other point, but there are a lot of panelists. But the good news is that we prevailed. And the good news is that the government understands that. And so in that kind of political tension that we have often around resource allocation for kids' behavioral health, we won. And so I think that's a good thing. And I also feel like, you know, having been in this business for 30-something years, you know, you win one, and then you have many, many more battles to fight and many, many more things to win, because nobody ever gives you everything the first time, right? So you got to keep going back. So, you know, all the mobilization that you guys did around the budget, you're going to be asked to do again. People are going to continue to ask you to help step up and give examples and help families give voice to the needs of their kids. I think one other piece, I think, which is important, because Tonia's sitting next to me and she's an early childhood person, you know, we haven't done enough on the early childhood side. We have work to do. And so that's another sort of big piece. And Jenny's going to talk about some other stuff related to clinical services. But, you know, there's work to do. But, you know, accept that we're moving into managed care, figure out how to use it as an opportunity, as Donna said. And I think we could end up really prevailing in a brilliant way for kids and families.
Thank you. So let's open it up to the entire panel, both for comments specifically on the opportunities and the limitations posed by the Medicaid redesign plan. And then also, we have providers at the table who really work with a wide range of communities, and I'd love to hear from you about what you need from the state. What do you need in terms of policy change? What are the priorities for the communities that you serve?
I'll take that. So I work at the Crown Heights Community Mediation Center, like I mentioned earlier, and one of our biggest projects is our Cure Violence project, which is a public health approach to dealing with gun violence. It was something adapted from Chicago, and we were the first site in Brooklyn, Crown Heights, to have that project since 2010. Because of the success of what we did in that program, there are now 18 sites over the 5 boroughs. So the model itself worked. And so in our work, we're kind of connecting with those who are most closest impacted by gun violence, those who are shooters, those who are part of various street organizations, those who have been harmed, have been coming home from incarceration. And our outreach workers and violence interrupters are people on staff who have their own lived experience, whatever social currency they have in their community. And so their job is to stop those people being harmed and causing that harm. And so, but you stop them from shooting, what next, right? So in 2012, we actually got some federal funding to start a therapeutic program for young men of color impacted by violence, and that's a program that I run. It's called Make It Happen. So I know we're talking about Medicaid, management, all this.
Talking about it
stuff.
all.
Yeah, we're talking about it all. With us, we're trying to, once again, we're trying to connect with those who are not walking through those doors of those clinics. Those who are not walking, who are not going and receiving these services because, you know what, let's be honest, they don't trust the systems that are supposed to be there to help them. So our approach has been very much about understanding that we're clinicians, we're bringing this work forward, but we have to understand that we need to build that trust. So we actually bring the interventions to our young men. We're there not just using the various evidence-based models, we're understanding that we have to borrow from the bits and pieces and really use a person-centered approach, saying, okay, what is it that you need, and figure out how can we collaborate. one of our foundations of our program is we really want to focus on how our young men have been socialized, on top of how that impacts how they handle traumatic experiences. So expanding what a victim is, right? So a young man that I work with, maybe part of a street organization, may act a certain way. Other systems will just find him as a criminal, defendant. I'm like, what else is going on there, right? The behavior is really there to keep you safe. So how can I build trust to get you to a place where you can start understanding your emotional experience a little better, but also acknowledging that the world outside is not safe for you as a black man walking through these streets. So how can I give you the tools to navigate that? So our focus was, how can we improve your emotional intelligence, right? Understanding that, at the end of the day, even though we're doing all this, you still might be stopped and be harmed. So that's really been our approach. What we need more people stepping out of those offices, really thinking differently about how we offer mental health services. I've worked in clinics. I've worked at Jewish Board. I've worked in a number of different places. I've worked in child welfare. I see one of my old coworkers right over there. But I feel it's really important to be in the community, be in the space, understanding that, they're not coming to us because they don't trust us, and that is on us. We're doing something different here, just like this with the managed care, what we're doing here, right? That's a different approach. We've got to change it up and not be afraid to be out there in community and be closely connected to people who need the help. And understanding that traumatic reactions do not look different from people to people, right? So that's been our approach here. Fortunately, I've been blessed to work alongside people in the community that have access to those who are most harmed by gun violence and who are actually some of the most traumatized people that we're coming in contact with and are not receiving the services. So really that community-based approach is huge, and if there's a way to kind of support us in that effort, that would really improve our interventions and have more social workers and clinicians out in the community doing this work with our, quote unquote, the word we use in cure violence is credible messengers. So having our supportive services alongside those credible messengers will do two things. The credible messengers using their credibility to get connected to those most impacted by violence, and then giving us that buy-in to actually do our interventions that we do in these clinics. We do in our different schools or wherever we're offering our mental health services. So I think that's very important to kind of really think differently, a little more outside of our ivory tower approach to offering help and support.
Thank you.
Thank you, and I'm so glad you raised this idea of providing services out of the four walls of the clinic, because I was actually going to pick up on that theme to point out that I think that's one of the promising features of these new state plan services, is that they really enable folks to get out of the four walls and into the community and to be able to bill for those services. And we know that asking people to come in to the clinic in and itself is a barrier to care. It just simply is. You have communities that are not trusting of that service system for a variety of reasons. We have families that have multiple stressors in their lives, and it is just too much to ask them to come into this center. We need to go where people are, essentially, if we want to increase access in communities. And this set of services really offers the promise not just to do it, but I think to fund it in a sustainable way. And I think that, like the Cure Violence Initiative, which does incredible work, and many other innovative practices have been funded through small pots of money. They've been funded through state aid funding. They've been funded through some city dollars, without a sustainable source of revenue and ability to bill. And I think that's another potential promise of this initiative, is that I know a whole host of contracted services we have in the city, we can only expand their capacity so much. Now there's going to be Medicaid revenue potentially that we can tap into and really open them up. So we can combine Medicaid revenue for youth who are enrolled in Medicaid with other funding streams to really broaden out the access to a lot of these more supportive services that traditionally insurance wasn't going to pay for necessarily outside of just straight treatment. And then I think in terms of what we need to get there, I think Gail was speaking a lot to this. We need obviously adequate funding for services, which we're very grateful has been restored to the budget. We need investment in provider readiness. We need to make sure that providers understand the opportunities to provide these services, to bill for them, have the infrastructure in place to do so. We have to do the same with our managed care plans. We need to understand, make sure that they are ready to to pay for these services. This is a whole new benefit package that managed care is new to them, that they haven't been asked to cover before, and understand the needs of the populations that they're going to be serving. And I really think we need to make sure families and youth understand the services. So the system's changing for everybody at once, and for those who've been, engaged in mental health services, we have to understand how services are going to be changing, how access to services are going to be changing, what new opportunities exist for them, and how you get to them. So I think we've got a great start now. We have monies restored, but we have a lot of work to do still to invest in making sure we can actually move this from policy into real practice and implementation. So.
So I just want to say something positive for a moment about New York. I do a lot of national work around child mental health clinical services, and New York City in particular, there's a lot of challenges upstate, obviously, but New York City has one of the best kids systems in the country, if not the best. I want to thank Susan Thaler and her colleague Anita Appel at OMH, who really very carefully built an array of kids services, from family support to a lot of specialized high-intensity services. Now, my perspective is very skewed because I have always worked with very high-risk families with a lot of clinical challenges and certainly a lot of social and political challenges. So I'm going to speak from that perspective. I think one of the most exciting things that we've been working on with the Department of Health is in the value-based payment world, where we're looking at how do we integrate screening, both moms and dads screening and baby screening, into the early childhood wellness part of the health system. And that has huge potential if it's implemented properly to actually identify families. And we always talk about kids. We have to talk about families, particularly when we're talking about high-risk populations or high-challenge populations, to identify things early in life that we can positively, I'm looking at Susan Chinitz here, that we can positively affect. We can do dyadic work with parents and children that is life-changing, and we can prevent the development of mental illness. I know as a high-end provider that trauma exposure is a major, major cofactor for the challenges our kids face. And very often kids who are facing those challenges are living in families that have faced those challenges on top of or below the community violence people are experiencing. So the concept that we can approach people like, bad things have happened to you, we can help you, we can maybe protect your baby, have them grow up healthier, is a huge win that we're even talking about that. When Jason Helgerson, our Medicaid czar, is talking about attachment as an outcome measure, we have moved very deeply into the real world. So that's really positive. The challenge is going to be, and I'm a clinical provider, the challenge is always having the resources to do that. And kids get the end of the stick, as we clearly see here. And I say to the adult people, if you don't treat children when they're young, they grow up to be ill adults. So why do you have all the money and you're just churning people through your services, and we have to struggle so hard to work with kids and families when they're young? But we have to push on this, because screening is one thing, but without staff to actually intervene, and that costs money. Now, managed care plans are getting it. They're beginning to get it. I'm looking at my friend Sylvia. We've been trying to sell a pilot, one of our big managed care plans, for a complex family bundle for high-risk families or high utilizing. We've been working on this for 3 years using the evidence-based models that the Foundling is so good at, because they work. So we're seeing real progress. Now, we know what we want to do, everything in the community that we can possibly do in the community. But the clinic services also have to work. And one of the reasons they don't work, I'm sorry, my friend Donna Bradbury, is because they are wildly under-resourced. So we have a clinic system for kids and adults that's moving to models that use per diem providers. In other words, they don't get benefits, that take junior people right out of school. Once they get their hours, they leave. And that's a resource issue. So clinics don't have to be as incompetent as they often are, but we've never made the investment in outpatient services that we need to make them actually work. They're not going to work for all families, but they should work for the families that they work for. And we need models for families that aren't going to come to the clinics, like MFT, FFT, and MST, et cetera. And we need a broader array of intensive services that aren't hospital services. We have 3 partial hospital programs in this city. One, you have to drop the kids off and pick them up yourself, so that excludes a large swath of folks, right? So I have kids in the hospital for 2 weeks, 10 days, 2 weeks. I can discharge them to my partial hospital, treat them for 3 more weeks. You know, they leave the hospital not when they're better. They leave the hospital when they're no longer acutely suicidal. So a little more time is really valuable. We need to build out that array of services across the boroughs, and we need to make sure our clinical providers are trauma informed. We spend a lot of our time at Bellevue taking kids off antipsychotics because they're angry. Okay, so that whole, and we're making progress. Complex trauma is a whatever that means. I know that's hard. I know what it means, but that we're making progress. So I want to just say I've been in this city since 1986, and boy, it was wild in 1986. And I see us really moving in the right direction. But fighting for the resources that kids need, you know, you don't. I have a very, I think, realistic perspective as a child provider who has spent my entire career, not anymore, working under the adult providers because they control the resources. And we need more of the resources to do this work early for kids and families in the right way. Our clinics need to work, our intensive services need to work, our hospitals need to work. Some of our hospitals are terrible in terms of the treatment they give to kids and adolescents. Not mine, I hope, but. And then we need to deal with the communities, and I work in the juvenile detention centers, so these kids, the lives these kids have had, you know, we have to reframe how we think about these kids and their families. So I think on balance, even though I'm usually a real pain in the you-know-what, I'm very positive about where I think we're going, but it all comes down to money.
Good morning. I think, so listening to everyone, I'm excited to hear that we're thinking about young children, families, communities. I think the thing I want to name is we also have to be talking about and thinking about how race, class, privilege, and power is engaged in those communities, how people think about and talk about children differently from different communities. That is essential in order to change the way we look at trauma, in order to change the way we look at depression, anxiety, anything going on in communities. If we are not naming that young black boys are being suspended at higher rates in preschool than in middle school and high school, we're not stating stuff that is happening to our children. And it makes it harder to be able to do the work because we're not owning that that's a problem. When auditors come out and read charts and don't understand what it means for early childhood, for a child who is experiencing trauma at a very young age, and their expectation is to do what an adult clinic would do, we have to shift how we look at charts, how we think about young children and families, how we hold race, class, and privilege in a way that is clear, that speaks to the language of teachers, staff, community providers. When you were talking, I was thinking, you know, when I listen to people talk about very young children and use the word aggression for some, but, oh, he's having a problem today, maybe mommy didn't do something for others, that is a problem. And so I just want to name that that has to be on the table too, because we leave it out often. We write it in small ways by saying we have to think about culture. We have to read and understand it. No, we have to ask families how to identify. We have to think about what's happening that's making people upset, angry, overwhelmed in their communities. Why is a mom yelling at her child instead of pausing? Sometimes it's because the amount of violence she's hearing about, she's struggling with, she's living with internally as a woman of color, gets brought out and is stated in ways that when people talk about the mom, I'm thinking, well, did you ask her what happened last night? Like, we have to just think more broadly about how we're holding these things. And that has to be built into the fabric of these new services. If you're gonna be going into communities and you're different from the family sitting before you, but you can't name that and then can't say to them, what's happening for you? What's causing this? That is a difficulty, right? So yes, it's great that we're gonna send people into homes maybe send them out to schools, but we also have to be thinking about how we help them develop an understanding of what the communities they're entering into live with, struggle with, have to experience every day, and have to walk into. There's enough research now, guys, for us to think about these things in very clear ways, right? There's research about Black men having a resting heart rate that is still elevated in the evenings when they're sleeping because of the level of stress they're experiencing. We have to hold this as something we're doing for young children, families, and communities. So that's what I keep thinking as I listen, and that I'm passionate about, and that I really think is important to hold in every conversation that we have around all of these new services and how we're rolling them out and how we're thinking about children and families in those moments.
So,
And I was going to add, kind of piggyback what Tonya just mentioned. So we're talking about going into community, offering these additional services. I'm thinking of adding the race lens too, because I may be a family, single parent, single Black mother with several children, whatever it is, and I probably have about 4 or 5 people from different agencies in and out of my house. I'm here to help you. The other person saying, I'm here to help you too. At the end of the day, we all want some sense of autonomy and control of the 4 walls that we bust our behind to keep over our family's head. But now I got the school watching me, I got ACS knocking on my door, I gotta bring my kids to HRA for an appointment. Now I gotta sit here and do one of these evidence-based practices in my house. I'm not gonna be that cooperative. Good chance I might cuss you out, because I had 4 or 5 appointments. So like, we have to be honest about when we're talking about this trauma-informed lens, we've got to really kind of keep a broad lens and also include ourselves as service providers and include how much harm we've caused and we are continuing to cause. So we're talking about all these great things. We're bringing all this money in, which is awesome. But we also have to understand that poor communities of color are over-policed, over-serviced, and with very little input from the community. And I think that is something that we really have to look at ourselves about. Okay, what is the best way, how are we gonna really collaboratively work with our communities here? So just wanna throw that out in the space too.
how do we, Tonya, I know you do really interesting work at the Jewish Board around building that awareness around race and class and privilege. I wanna open it up to the panel. How do we build that awareness and that better practice into the overall system? How do we require better practice?
One thing that I think is it's a real challenge, and when you look at the medical side of the service system, it's usually middle class or upper middle class people who are usually not Black or brown, who have not had an experience of struggling about money, and who have not the same level of community violence. And how do you educate people about that? And I think one of the most effective things to do is to actually go into people's communities and be with them in their communities. And I always encourage our trainees to do that, because if you don't, people don't understand poverty at all because they've never lived with it. And when they see it and are in people's homes, it's very meaningful for them, because we're experiential learners, and it's not until we see what other people are living with. Now, when you're working with the child welfare population, that it's particular. I mean, everybody in that system, everybody in our jails is Black or brown, everybody. And the issues of race have to be integrated into how you work with those kids. I agree completely. The system has to move. And the other question is, how do we recruit more people of color into our clinical care system? I mean, that's a big piece of work to get Hispanic and African American trainees into the field. And I would look to you guys to help us with that, to direct young people interested in this kind of work to us.
So, it's interesting. I'm sorry, Marnie, do you want to? I was just going to say, the tools that we use to do assessments and screening are also tools that we have to look at from this particular lens. We need to make sure that there's no implicit bias and that, in fact, they are used properly to open the door for conversation, communication, and service, and not shut the door so people don't feel diagnosed and judged. So that's a piece of what we have to work on. I think training and supervision is critical. I think building the rest of the system and continuing to do the Medicaid redesign work with families is critical. Maybe that needs to be an enhanced piece of the work. There was work with families to develop the early design, but maybe there needs to be more work going on. How does it roll out? What does it look like? Are we going to test to see whether the interventions are effective? Should we look across geographies and populations to figure out whether stuff is working for people and what in the models don't work? If you're living in a small place, or if you're living in one room in a homeless shelter hotel, you can't get services there. And by the way, why would you deliver services there? People need to live in the world too. So there are all kinds of accommodations that we have to make to people's living circumstances.
Why wouldn't you give services there?
Well, you could. I'm not saying that it's a bad thing to do, but people also want to get out of their one room, and it's them and a kid and a bathroom and a hot plate. So it doesn't mean that you can't do it. It means it's not the only place to do it, that there are other ways to give people freedom and choice and to help people integrate into the community when their life circumstances are not really going to do that for them. It's also very chaotic in shelters, or hotels. I'm not saying it's a bad idea. I'm just suggesting that if you live in one room with your children, it creates a unique set of circumstances. You can deliver services there, but that might not be where people want to be.
I think New York City, and I'll give a shout out to DOHMH and the broad spectrum thinking that happened with the New York City roadmap, because I think one of the things, the mental health roadmap, that it allowed is for people to begin to think about how could you deliver a broad array of services to communities without always making it pathologized, right? How do we do it without always pathologizing everyone, giving someone a diagnosis? And so they did a really nice conference on something they call task shifting, which is basically really thinking about outside the box around how do you support the actual providers who exist and are already present supporting families? How do you give them a mental health lens, social emotional lens, a thinking lens that broadens the spectrum of how service delivery happens even in a homeless shelter? So we're in homeless shelters doing early childhood mental health consultation. Why? Because one of the homeless shelters has 165 families, but 300 children under age 3. 300. That is a population that's not being served. No one's referring them anywhere because the goal in that shelter is to get them into their home next.
And they're little.
And their babies.
So they don't make trouble.
And so there's a lot of ways that we have to think outside of the box. What you were talking about is important because in communities, there are so many ways that we can touch young children and families that doesn't happen in a clinic setting, that doesn't happen in a school setting sometimes even though schools can provide a lot. As a teacher, I can say if a school is rich and has a rich social emotional curriculum and can pause to think about what may have happened versus just immediately going to a behavioral strategy, they can make a huge impact on children. But I also think that in the homeless shelters, wherever children are, there can be an impact. I really believe that.
So I do want to spend some time on City Health and Mental Hygiene Department and the work that's being done to expand services. I also want very much for us to talk about the challenges around building capacity, and I want to talk about funding and what we know about how the expanded services are going to be funded. Will they be at sustainable rates? What do we know so far? So maybe let's go in that order. And Marnie, do you want to talk a little bit about what the city's doing?
Sure, I'd be happy to. And before I just give the overview, I just wanted to just before we leave this really important topic of racial equity, just wanted to thank you for raising it, and also just to say that this has been a major priority of our administration of the city and the Department of Health and Mental Hygiene. And we have an internal initiative called Race to Justice, which is really trying to build our own capacity to understand racial disparity, understand contributors to it, including racism, structural racism, and to build our skills to address it. And so from the children's perspective, I know you raised issues of measurement. Some of the things we're doing are really trying to examine from a racial equity lens, what tools are we using to measure children's experiences out there? Are they the right tools? Are they sensitive to the experiences of the diverse racial and ethnic groups we have in New York City? The evidence-based practices we put out there, like who is the evidence on? Who was it effective for? We have a very diverse city. Who was it tested on? Are we promoting the right evidence-based practices? How do we support our contracted network of providers to do this work with us? What do they need? How do we partner with communities, which is a theme of Thrive NYC, which thank you for raising, I'll get into in just a second, to hear from them to do this work better. So I just wanted to point out that this is an initiative underway and that we really are taking very seriously, and there's a very strong need for. So just segueing into some of the work that the city is doing, I'm gonna just give a quick overview because we partner hand in hand with the state, but we have slightly different roles within the system in New York City. So let me just say a little bit about what we do in our system. So the Department of Health and Mental Hygiene, we do contract also for services, a variety of community-based services, and we operate the single point of access for some of those what we call higher-end services for children who have higher-end needs. We do research and analysis on the population level needs. We do policy and planning work, public health functions essentially, partner with the state on planning for the local mental health system, and we do a lot of prevention and promotion. And so I'm going to pick up on that right now and speaking about some of the ways in which we've expanded services. We've talked a bit about early childhood and the need to do more for kids 0 to 5. We, in recognizing that, have an initiative called our Early Childhood Mental Health Network, and this was really, a lot of this work was catalyzed under Thrive NYC, which many of you may have heard of, maybe not all of you, which is a public mental health plan, right, basically for the mental health of all New Yorkers. And it's based on 6 principles. One of those principles is act early. So how do we not wait, right, until problems are really strong and serious and could have been averted? How do we work better with children? So this principle of act early has catalyzed like a lot of new and innovative work that we've been able to do, and one of those initiatives is this early childhood mental health initiative. So we've developed a network of 7 clinics that are specialty clinics. They specialize in the needs of children 0 to 5 and their families, and Jewish Board is one of our partners in that. They operate 2 of what we call these early childhood therapeutic centers. And what's really great about this network is that it's not only providing clinical care and dyadic care to children and parents and caregivers who need it, but it's getting into other systems. So it's what we were talking about earlier. We have consultants, clinical consultants from these centers who go and do mental health consultation in early care and education settings. So there's 75 sites that we are paired up with, and they can do consultation to staff at the classroom level from a mental health promotion, right? How do you build a warm, supportive, nurturing classroom for all of your kids? And then maybe there's a tier of kids who need more. They need more supportive interventions, a little bit different strategies, one-on-one. They do case-specific consultations as well with the staff and with the parents and caregivers if needed, right? So how do, in the classroom, right? How do you work better and promote and support these children, right? And then if truly needed, they also have expedited pathways to refer children to these clinical centers. So, and that we hope is for our smallest number of kids, right? So a lot of the work is trying to get ahead of that, is trying to, be done before that point. We've also done, picking up on this theme of capacity, trying to embed services in different places. So we're working with an initiative called the Mental Health Services Corps, and that is really trying to increase the number of clinicians, not only in both clinical settings, but also in primary care settings. So to build, essentially, people will more often be comfortable going to their primary care doctor. They're taking their child to the pediatrician. than having them engage in a specialty mental health clinic. So we have 46 clinicians who are embedded in child-serving settings. It's a mix of primary care settings and clinical settings, really to enhance their capacity to do that work with children and families. So how much more time? I don't know. We've got a whole spread of services we could talk about, but I don't know how much more time you want me to spend on.
Not a whole lot
what
of
the
time.
city is
As quick
doing.
as you
Okay,
can.
that's fine. So I'll just touch upon two others without getting into the details. And again, really speaking to the themes here, really I'm trying to get to that we're trying to work very much in the space of prevention and early intervention, and also trying to create new pathways to care and provide care in a variety of settings that aren't always the clinical settings. So we have a parent coaching initiative, which is really working with parents of children 0 to 5 to increase their capacity to promote attachment between themselves and their young children. We know that secure attachment is a critical foundation for children's healthy social and emotional development. And it's preventive in nature in the sense that the child doesn't need to have any indication of a problem. It's open for any, for a parent of any stage to engage in. And we are also doing, we've always really been big believers in peer supports. So we have, with the state support, thank you for many years, invested in a network of family resource centers that have both support families of children who have either behavioral health challenges, they either have them or are at risk for them, and provide them with peer-to-peer support, system navigation, advocacy, and also the same for youth. We have youth peers as well who are there to support the youth themselves. So in the interest of time, I'll stop there, but a lot is going on within the city, and we're also really excited about the new investment in these services because, as I was mentioning earlier, it helps us to now tap into new revenue streams to do some of this work.
Thank you. So it seems like a lot of issues actually come together nicely here, right? You've talked a little bit about new streams and the possibility for capacity expansion. Gail, you also talked about the pitfalls of creating pilot programs that then can slip away. So let's talk about the potential and the challenges around capacity expansion, and let's not leave out money. What do we know about funding for the new services, and then providers, if you want to talk about challenges around the workforce and hiring, and other issues with capacity?
Well, just generally speaking, I can say that so $15 million was allocated in this year's enacted budget. Okay, so we've got $15 million that becomes $30 million with a federal match. So when we provide Medicaid reimbursable services, we draw down 50% from the federal government. So we've got $30 million in this year's budget to begin implementing those new services. As Gail said earlier, we're looking at a package of 3 of the state plan services. So all of this, by the way, is contingent on CMS approval. So this is, I'm describing what we want to do. We do need to sit down with CMS and get their approval for this. But what we're hoping is to be able to implement 3 state plan services, and so we've got the money in the budget to do that. In terms
is $30 million a little? Is it a lot when we're looking at this
world
of need?
Everything's relative. But
Well, it's
but
more than
keep
zero,
it's
which
more
is
than
what we
zero.
have, so that's good.
It's
but
more than
like a
zero.
down payment.
And keep in mind too, so the state fiscal year starts on April 1st. And so if we're implementing in January, we've got $30 million for a quarter of the year, for that last quarter of the fiscal year. So from that perspective, it's actually it's a good amount of money. And it is sufficient for what we're proposing to do and what we're hoping CMS will allow us to do.
Just the early childhood stuff is so important. I just want to say it again. We don't have a strategy for scaling it. Okay, and the first 1,000 days of Medicaid, which came out of the value-based payment stuff, is really focused on what you do in the first 3 years of a kid's life and a family's life with that kid. And it's great that you guys are it's really supporting the expansion of early childhood mental health. You know, it used to be that clinics had a license that said they couldn't do anything to anybody under 5, and we've moved beyond that now. But how are we going to resource early childhood settings, primary care settings, you know, to do the work they need to do, and to work with the kid and the parent, because often it's the parent who you need to work with with the kid. So we don't have a strategy for that. I just want to warn us, so it could all go away in a flash. And I don't know, maybe you saw that coming out of the value-based payment stuff, but I didn't see the strategy of how we would have a systematic way of supporting mental health or developmental providers in these settings to do the early intervention and prevention and target the kids who have higher levels of need to the places that can actually serve them. So that's a capacity issue we need to watch, because it's all talk unless we have that.
Mm-hmm. Well, and also the first 1,000 days of Medicaid are their pilots. So that's fine. We've had, 30, 40, 50 years of pilots. And so, the question is, how do you scale it? I think Jenny's point is well taken. The scaling has always been the issue for kids and family services as it relates to behavioral health. And so I think that's really, that's the next frontier. I mean, one place, which is why I pushed so much on the 1115 waiver and talking about Medicaid eligibility, is that it's a steady funding stream, and we can count on that. Now, again, we have existential issues in Washington that I can't really discuss. But the reality is, that if children have access to this public health insurance coverage, it allows them to have services paid for. And then there are some services that need to be factored into the new benefit package, which we have not really addressed. And some of those are a hybrid between health and behavioral health. And so there's some questions about what the best arrangement should be for delivering them. But the fact is that without the health insurance coverage, children can't get service, and their families can't get service. And so, my issue, frankly, is about securing resources and securing access to the insurance products. There are people in the room who know way more than I do about programs and how to deliver services to kids and families to get a good outcome and to help people have the best possible lives. But it all takes money. So, that's got to be a very, very focused challenge for us, and it has been for many years. But we prevailed. So, it's not a ton of money, and certainly $15 million isn't going to be enough to fully roll out the entire managed care redesign. It's, higher than that, 3 digits higher, maybe, I don't know. But, but we take it one step at a time and we figure it out, because I also want to say that if we actually had gotten a full funding for the entire Medicaid redesign in the budget in April, the system would have collapsed under the weight of its own ambition, because we just are not there. We have workforce issues, there are training and supervision issues, people have reconfiguration they need to do in their own organizations. We've got all of these other issues about whether the instruments we're using make sense, what models are the best ones. So, I'm not an incrementalist, but I actually think this is going to work to our advantage, because we can kind of ramp up based on the limited capacity that we have and do a better job.
Great. Thanks, Gail. I just want to add something else too, that you hear me focusing a lot on the Medicaid redesign stuff because it consumes a lot of my time and attention, but and it's certainly very important. But I guess I just want to make the point that the Medicaid redesign piece is necessary but not sufficient, right? Like, I don't want any of us to get caught in this trap of this is going to address every single issue that we have, because that's nothing could be further from the truth. But I do want to just mention one thing while we're on sort of early childhood and prevention, that the Office of Mental Health has been venturing into the area of prevention. It's new for us, right? We're accustomed to dealing with people on the far end of the spectrum that are, dealing with serious mental illness and serious emotional disturbance on the kids' side. But we have a healthy and growing prevention arm. And I just want to mention one particular model, which is Healthy Steps, that we invested in a few years back before the first 1,000 days, and is now getting, luckily, more traction because of the first 1,000 days. We're at, I don't like to use the word pilot, but we are sort of at the pilot stage. But one thing is critically different with the way we're implementing this project, which is we're building in an entire sustainability piece into that pilot project with the goal of making something like Healthy Steps, which is a primary care-based prevention model. It's true prevention. It's true primary prevention. So we're talking about a developmental specialist being embedded in a pediatrician's practice in order to get to families right from the very beginning with babies and very young children, to address a trauma, to mitigate the effects of that trauma, to offer home visiting, to offer other supports and refer out for other services. It's just really critical that we look at the entire spectrum, and I'm so glad to hear about the work that's going on here in the city on prevention. And we need to get very creative about approaching payers, particularly Medicaid managed care plans, about seeing the value of this. A lot of the predicament around prevention and early intervention is that we know that it works and we know that the savings will come, but it comes longer than a payment cycle, right? It comes years down the road, but we all know that these savings, and the savings accrue not just in health, right? They accrue in education and child welfare and juvenile justice. That's where you see a lot of these savings. So we've collectively got to get really creative about convincing the right people that these early services are the right thing to invest in, because there is a payoff down the road. So there's a national organization called 0 to 3 that we're working with. They own the Healthy Steps model, but they do a whole lot of other work. And they've done some of this work nationally to demonstrate the value of primary prevention.
So one issue, we've spent a lot of time on early childhood, which is really important, but we also need to think about what models work for families, for complex families. We know it's not the clinic. And there are very strong evidence-based models that work for those families. How we integrate into the community in those communities to get to those families is really, we've had a kind of one-size-fits-all clinic model, and it doesn't work for a subset of families who really need intervention. And you can't be talking about children all the time. You have to talk about families. My experience in the 90s running a mental health clinic for families affected by AIDS was that multi-generational trauma was a major issue, and you couldn't help the kids if you didn't help their parents. So we need to really think about how we adapt our models and use evidence-based models that we know are going to produce an effect and integrate them into communities in a way that works.
And think about how we pay, how we cover those payments, right? Because the way the structure is currently built and the fee-for-service model that we do, it's very restrictive around minutes and this and that. And when you're trying to build and support families, you have to meet them where they are. And maybe they get to a 45-minute, 60-minute session, but there are times when you have to start where a family is, but you can't bill a family session that's 30 minutes, right? So the way the structure of billing even exists doesn't sort of lend itself to what we're describing about being a little more open to what's needed for families in our communities.
It doesn't pay for the half-an-hour subway ride each way, right?
That's
So
right.
you guys, Kenton, go ahead and make your comment, and then I am contractually obligated to turn it over to this audience.
Okay, real quick, I was the waiver service provider for a day, and yeah, so there was a reason that was only a day. But I also want to kind of just, we're talking about early childhood and the families, which is all extremely important. But there's also a population of youth that are disconnected from families and systems that we have to kind of keep in the space. And what is the intervention going to be? I mean, the work that we do in Crown Heights, a majority of our young men that we're working with are disconnected from their families for whatever reason, or their definition of who their family is not by blood, right? So we've got to figure out, these are people who need just as much support. And I mean, I'll tell you this, we're funded by OVC, Office of Victims of Crime, and we only have 12 sites across the country that have this similar funding, supporting male survivors of violence. We're the one of 2 sites in New York, and it was me and 2 other staff members on my team. That's not it. We don't have enough capacity. We don't have enough money to have a larger staff where we can train them to kind of do this kind of community-based mental health services, which is non-traditional, and I think that's really important. So I'm going to keep it very brief. I know you're contractually obligated to throw
I
it
know,
out
but
here.
can I just say, when we say family, let's not forget fathers, because I think we often do.
Great. So we are setting up 2 mics, one on either side of the room. Please come up and ask your questions. And the great favor that I ask is that your questions are, in fact, questions.
Okay, I have to revise what I was going to state. As an African American with many years of experience, community-based, also in public service, I wonder what members of the panel would think about, to me, transcending all areas, even a child coming up in the communities that are neglected. Think about, as with the social work profession, we're mandated to be trained in diversity. And so to me, as an African American that came from Harlem, if I didn't receive my education as I did, to have the mother that I did, I wouldn't be aware of your population to serve them, which I have too. So to me, what do you think about it being mandatory for any professional in any area of social service, meaning servicing any human being, like as a medical doctor, being mandated as a part of their licensing requirement to receive diversity education? Look at the parents who were out at Wall Street yesterday. They're concerned about it at school. To me, it needs to be throughout the city.
Anybody want to comment?
So I think that that's an important statement. I think that race, class, and privilege and the work around power and privilege is an ongoing work that we should be doing for our entire lives, right? It can be a start for schools to ensure that they open the conversation up, but I think through reflective practice, supervision, and support, it has to be a constant conversation. We all carry biases. We all struggle with trying to understand differences, learning more about different people and their cultures. It is an ongoing conversation. So yes, I think that educational settings should include it in their curricula. But I also think that programs, staffing, supervisors, agencies, government should be thinking about how do you continue the dialogue so that it's a constant conversation.
I agree. Makes me think of kind of how agencies operate. And it almost kind of reminds me of this like Chris Rock joke. Chris Rock joke, he talks about he's Chris Rock, he's a comedian. His next door neighbor is a dentist. And he's like, he's not the best dentist in the world, he's just a dentist. And he makes this statement saying a black man has to fly where a white man can just walk to. And I feel like that's been my experience working in the field, right? When I've worked in the front line, a lot of agencies, everyone looks like me. You know, we're in our communities doing all these things, but as you go up the ladder, not a lot of people look like me, making those decisions, driving those policies. That is privilege. that is privilege that we really need. Like I said, as service providers, we need to look in the mirror and say, how are we causing harm in these communities, and how are we causing harm to the people that are supposed to be providing support and services? So then when I used to work for the city agency, I'm not going to say which one, I remember staff members used to really get into it with clients, and I was like, whoa, I can't tell who's who. And I'm like, this is a problem. This is a problem of privilege. This is a problem of kind of something that like it's above my pay grade. But I think this is something that really needs to be added into the conversation, and really people need to relinquish some of that privilege, in my opinion. So
how do we build these conversations into policy making? How do we make sure this is in the room front and center when we're creating policy?
So there's SAMHSA, the what is it called? This Substance Abuse Mental Health Services Administration. So SAMHSA has their sort of premier children's model is systems of care, and at the Office of Mental Health we try to build systems of care values into really everything that we do in all of our policies, and cultural competence is a critical part of that. And you know, I like the comments so far because I think, you know, training is certainly should be happening in every graduate program, every undergraduate program for that matter. It's not enough just to take a class or to get a certificate. It really needs to be baked into an entire program, and it from the ground up with policies. And so, you know, one way that we try to accomplish that is through systems of care, really, which talks about also being family driven, you know, youth guided, you know, using the least restrictive services first. I mean, all the stuff that we know to be true in services, but that cultural competence piece, we could really pull that out and, you know, really highlight that.
I just want to say one shift I've seen in the clinical world, which is very important, is the trauma shift. So when you move from, you know, what's wrong with you, you know, to what happened to you, that's the classic line, you move away from pathologizing people. You do need to understand how trauma affects people, and it does have a real correlation with mental health problems. My boss is an early childhood person, and if a kid under 5 has experienced 4 or 5 more adverse experiences in that time period, they have 100% chance of having a psychiatric diagnosis, usually in the anxiety or depression realm, right? So, but that's an important lens, and it also can be broadened from the individual experience to the community experience to institutionalized racism. So I think that's progress that we are more and more of us, not all of us by a long shot, and certainly not in the adult world very effectively. The child people are beginning to think about experience and symptoms that way.
Hi, I'm from the Administration of Children's Services, and I have a very maybe practical question about implementation. So I think that I heard right that services for Medicaid redesign will start in 2019. The original plan was that foster care would be rolled into those services in 2019. So I guess one part of my question is, are foster children now going to be also delayed by 2 years? And then also kind of associated with that, in terms of implementation, our foster care agencies in the city have started to apply for licenses so that they can provide these services to our children. But we're actually having a tough time now that they've all gotten their licenses actually enrolling the children, because there's a lot of questions about when those kids will actually get their services.
So at this point, assuming we get CMS approval, so the foster care transition would happen July of 2019. Okay.
One of you said Cuomo cut Medicaid funding, Medicaid assistance funding. Did he restore it? Or is his money still in his pockets? You know, as you know, he's seeking re-election this year. And of course, if he gets re-elected this year, that's another 4 years of pure hell, with a tied to wacky tacky tacky. So all I want to know is, did he restore that funding? He did.
He did. Mm-hmm.
Is there any particular why he cut it in the first place?
Well, I mean, I don't know. This could go on for a long conversation, but the state operates with a Medicaid cap. And it's designed to try to keep spending under control and to sort of push more spending to downstream services, is what they call it. Things like prevention, early intervention, community services and so forth, and to keep people out of emergency rooms and hospitals. And so,
Would you just like to say at Bellevue, that's not work.
so thanks, Jen. So, so the idea is that we need to build the new children's Medicaid redesign within this, with a constraint of this overall, what they call global Medicaid cap. But we did it. So we have a down payment on the future, which is good. And now we have to figure out what to do about getting the rest of the money, and keeping it within the Medicaid cap or some other construct.
So practically, weren't we expecting 200 million and we got 30?
I don't think we were expecting 200, Jen. But to tell you the truth, I didn't have an expectation of an amount. I didn't really know what we could phase in year 1 versus year 2, year 3. But we have a long way to go. And we have to figure out how to do it, keeping in mind that we want to be prudent stewards of taxpayers' money, and that we want to deliver services that are of value to the community. So we have to figure it out. And our ambition, because you always reach for the stars, right? We try. But that doesn't mean that we actually know how to get from here to there. And so, at least in this case, I think the resources are there to deliver services that we know are going to work and we know how to get to. But we've got a long haul. We've got 3 years of budget advocacy ahead of us at a minimum, and that's just the facts. So, as much as I was disappointed that the governor's budget didn't have the money in there, like I said, the budgets start out one way and they end up another way. Sometimes your stuff falls off the table, sometimes it gets back on the table. That's somebody's job, which really would be somebody, all of us. We got to get it back. So we have a couple more years left of hard work to try to get those resources in place. And at least for me, because I don't deliver direct services and I don't see families face to face and have to deliver services, I feel like if I'm going to make a contribution, it's trying to figure out how to get those resources so that you all can do your work. So that's my deal. But so, we don't have to trust everybody, but we have to say thank you to them when they do the right thing. So one other piece is remembering to do that. So I tell myself that every morning. So I need to actually tell the governor thank you for what he did, and thank the legislature also, because it was a big lift for them. And starting from nothing, 15 million grossing up to 30 million is like not nothing to me.
Okay, but you know what to do in the future.
What?
Participate in civil disobedience outside 633rd Avenue, also in Albany.
Well, we'll talk about that later. I'll come and see you before the
Since he thinks he's down, he still thinks he's down with OPP, like Naughty by Nature.
Thank you. Actually, I just want to say quickly that I learned that we do have the room for longer than anticipated for people who are able to stay a bit longer. And I'm going to use that as an excuse to throw out a question about managed care insurance companies. Does anybody have concerns about the potential for service denials in that model of care management?
It's not so much, I think the managed care companies are getting, you've got to remember, most kids are in Medicaid managed care now. They enrolled everybody in the 90s. And I think the managed care plans are getting smarter about what they need to do, and I think we need to really push the managed care plans on the kids' agenda. That's really important. They don't like to pay attention to it because it's not a lot of money. It's a small amount of money, so they're not really interested in what they can save. They need to be pushed. The way the managed care, they don't so much deny as they obstruct cash flow. And everyone who ever runs a clinical service knows this. But I think there are opportunities now to get in front of them as a child advocacy block and make them, they're the ones who are going to have to pay for developmental and mental health professionals in primary care. There's going to, because they're going to have to do that. So we need to push them.
Yep. Hi, it's Mike Fagan. Gail mentioned basically failing under the weight of our own ambitions, and I couldn't help but think of the adult system rollout and how basically the health homes were rolled out and now are in danger of being cut, and how the waiver services, which HCBS services, were rolled out, yet very few people subscribe to them, and so all those services not all, of course. Many of those services are in danger of collapsing at this point because there is no money flowing in. I'm sure you guys are watching that process. I'm watching it with a little fear and looking toward ahead toward the children's system. What would you do differently?
That's a great question.
So I think one critical difference on the kids transition, and let me just say that the kids transition, we were very deliberate from 7 years ago, saying that we wanted the kids transition to come after the adult transition, just so that we could learn right from this.
And you have the advantages of parents. It's not like they're not homeless in the streets.
Well,
which
some are.
In most cases.
But I think besides learning, and we are watching very carefully the adult transition, and the teams that are working on this at the state level are the same teams that worked on the adult transition, with the addition of kids program experts. So we're learning from all that. I think one critical difference in terms of the HCBS services, the advantage that we have on the kids side is that the HCBS services already exist. We have a network of providers that are solid providers. We have an understanding about how these services work and how they're to be delivered. On the adult side, that it just simply wasn't there. We started from scratch on the adult side. Same with health homes. Kids' health homes have been up and running for about 1.5 years now because we had transitioned on the OMH side, our targeted case management had transitioned to health homes. So we have a solid foundation of health home care coordination as well. So I don't think we're going to have anywhere near the level of challenges or the slow uptake in services that happen on the adult side, on the kids side. I think we're still going to have to watch, and we will, of course. And we'll have the same sort of round tables that existed on the adult side to hear the concerns also about, the issue about possible denials was raised. And I just want to say that, we'll have groups of providers that we meet with regularly together with the plans to hear those concerns and to nip that stuff in the bud.
I won't say anything because I have nothing good to say about health homes. I think that the one advantage on the children's side, I never thought that what we needed in our system was more care coordination, particularly care coordination that's disintegrated from clinical services. It doesn't work as well as it does, and as it does when, I always thought OMH should take all their care management money and divide it up and give it to the clinics, because we did that in the 90s with AIDS money. We had case managers that were part of our clinical team, and it was much more effective. One of the challenges with the HBS services is the rates, and on the adult side, they don't cover the cost of doing the business. And they're also, sorry, Donna, they're also incredibly complicated. So I work in a system, health and hospitals, that couldn't ever figure out APGs. They're not going to figure this out. So I think there are a lot of challenges. One positive thing on the kids' side is the health homes are integrated more into the kids serving system. They've been integrated into the foster care agencies, and that's caused those groups to really organize and connect and develop continuums of care that are stronger than they were. That's a benefit from vis-a-vis the adult side. But care coordination is not the issue, in my opinion. It's services that work.
Yeah, thank you. It's made insurance companies very wealthy in that they've gotten all of these HARP care managers now who are calling people who don't have phones.
Right. Yeah. Yes.
Thank you.
All of our kids have phones, right?
Good morning. I have a question about the managed care role in this transition. My name is Danielle Thomas. I actually recently started working at Fidelis. And Jenny, don't roll your eyes at me.
Almost as bad as Cigna, right?
And, having been there for a short period of time, I have many observations, one of which is that there's a real lack of collaboration between the managed care companies and the community-based providers, and really just the provider community in general. And I wondered what the state has planned in terms of educating and promoting opportunities for collaboration between the managed care companies and the provider community throughout this transition.
Yeah, that's great. So those round tables that I mentioned will be one venue for that. But we have, so there's, we work with folks at NYU, we call it MCTAC, the Managed Care Technical Assistance Center, and they are extremely helpful with us in terms of creating additional venues for meetings between providers and plans. And we used to joke, I think on the adult side, they joked and called it speed dating, where they would set up these conferences where plans and providers could meet, sort of very quickly in order to then follow up and develop more in-depth relationships later. And we'll be doing that on the kids' side as well. But I think there's no, I think we have to be extremely liberal in our thinking about providing as much opportunity for that as possible, especially on the kids' side. I know the plans are very nervous, particularly about the foster care population, because it's been so far removed from what they do. Exactly. So, and Jenny mentioned that a lot of kids are already in managed care, but with the exception of a large portion of the foster care population. So, anyway, your point is well taken, and we do have plans to do that, and I think I'll be encouraging as much as possible of that.
I'm grabbing the microphone. Right.
Oh, Jenny, can I?
Well, but one challenge we face in the kids' world is we don't have HARPs. And HARPs have, my understanding on the adult side is that HARPs have forced, they're being managed by OMH, and they have forced real relationships between the insurance companies and the providers. And I think that's really going to be a challenge on the kids' side, because we're going to have 11 payers with a foster care liaison, that's the plan, and that's not going to solve the problem. We have to have real relationships.
And just one thing I'd add, at the city levels, we have something called the Regional Planning Consortium, which is a local body that brings together all of the major stakeholder groups, individually as stakeholder groups and then together as needed, to really monitor and talk about what's happening with the implementation of Medicaid redesign on the ground. So this has been robustly implemented on the adult side. We also have several groups that have been meeting for a while on the kids side, including we meet regularly monthly with the managed care organizations themselves. Recently started one with the care management agencies. We've had ones with children's health homes. And so essentially, and I know that on the adult side, they've brought parties together for networking, for other opportunities, and for joint problem solving. So we really look to that vehicle in the city to surface the issues and to make sure that the stakeholder groups are coming together in ways that they need to be.
Well, and now that the resources are there, because we thought there was going to be a 2-year delay, there was no reason to convene. So now there's more of a reason to do that, and thank you, Marnie.
So this is going to be really a disaster for the foster care population, because there's so much cost sharing between health services. I don't discharge a kid from my hospital if they don't have a place to go, and I still get paid because they're Medicaid fee-for-service, within reason, obviously. But I'm not going to be able to do that anymore, and we will because we're Bellevue, but other hospitals won't. So I don't think we're prepared for this. I really don't.
So we've got 2 more questions on each side. I just want to check in with the panelists if you guys are okay to stay for a few more minutes, and if you're not, then you're not. Thank you. All right, let's move it.
I have a question about managed care. My name is Guy Loving. I'm a family advocate for the Family Resource Center in North Bronx. One of my questions is the timing. It's not about not paying for a service, but the length of time that the service will happen. I find that with managed care and dealing with them in the adult population, they will cut it off after a certain amount and say it's not working. Like, we have groups, like family support groups, and a family can only be a member for 3 months, and then we're supposed to, from what I'm reading, when this kicks in, they're out of the group. If a person has a substance abuse problem and they have to go to NA to a group, this is an ongoing process. How are we going to address this?
That's the question you were asking about. What's the impact of? I think it's going to be a real challenge on the kids' side. That's what I was just saying. When we make the transition to Medicaid fee-for-service for those kids, which allows us to have much more flexibility. That's why I'd rather have something like a HARP for kids, because then at least you have one organized way What kills us in the provider community is multiple payers and everybody doing something different and no consistency. And it's really hard to hold 11 payers' feet to the fire.
So I'm going to, you know, I mean, people will find this ironic, but I'm the glass half full at this table among the few. But so let me just say, you know, we are not powerless in our conversations with the managed care companies. And all of this sort of, you know, anxious depression that we have dealing with these insurance companies, it's our own, some of it's a little bit our own doing. And so, you know, we need to create venues where the conversations can happen and we can challenge people about practice that we don't like, where the state regulations and their rate setting processes or other, you know, where the regulations get in the way of good service, we should be advocating to change them. And so we're trying to transition a legacy system that was already fragmented and crazy, made no sense to anybody, into something that's a little bit more coherent. So it's not going to be smooth. But, you know, and I know at the provider level that people are really juggling the challenges of high caseloads and working with people, and it's very difficult on the front line and being on call and whatever. But there's a whole nother group of people, middle managers, senior managers, execs of the agencies, who are quite capable. They have paid lobbyists. There are people who do this work on behalf of the people on the front line to try to change the system. And so if we feel that there are institutional barriers or regulatory barriers, then we should identify them and work through whatever channels we can to fix them. I don't think and there's a finite number of them. That's the other thing. It's not an endless number of things that have to be changed. There are a finite number of tools that we can use to change things. There are budgets, there's regulations, there are program design, and there are processes. Those things can be fixed. In partnership with government and in partnership with the managed care organizations. But it can't just be this kind of passive thing where, like, we just wait around for them to tell us it's okay. It doesn't work for me when I have to deal with my own managed care company for my own health care.
That's why I asked the
question.
So
it's wrong for us to let that happen for families over and over again on an individual level. We have to figure out how to change it for people who have other things to do with their time and other challenges to carry.
No, it's okay. Thanks for that. And just to add to that, I mean, Gail's absolutely correct. So the state has tools at their disposal to monitor the plans, right? And so we have a contract with them. And what we've done is we've created language specific to children's services to insert into that contract. And the expectation is that, you know, that the plans will sit with us and understand the values, right, of these services. They do have a lot of learning to do. There's a learning curve, and we're engaged in that process with plans to address it.
That's why I brought it, because I would like to see it addressed. I have not heard it.
Absolutely.
And the second thing is, you said there are 7 clinics being opened by Jewish Board.
Perhaps maybe you're referring to the Early Childhood Mental Health Network that I was describing, that we have invested in 7 clinics throughout the city to build their capacity to work with young children and their families. 2 of them are operated by the Jewish Board, so our partners right here. Yes.
Okay. All right. Thank you.
Sure.
Thank you.
Hi, everyone. Excuse me. My name's Elizabeth Rogers. I'm from MHA, and I'm also a member of NASW and their Coalition for Race, Diversity, and Intersectionality Committee. And I just wanted to bring it back to the racial equity lens for a second. I think as a white clinician, what I would have hoped for from people who were on the panel is that when asked about the training, that they would have taken some ownership and maybe said the anti-racist work that you were doing at your agency, and if not, how you could bring it to your agency. Because I think as white clinicians, we need to be really aware of what power and privilege we have in different agencies, and this includes who we're promoting, what trainings we're offering, what our clients have been through, but also to what Kenton said too, there's a lot of frontline staff that are people of color, but the higher you go up, it's mostly white people. And so if I'm a white person and I have power, I really need to develop my own awareness of it. And I can't continue to ask people of color to do that for me. I need to do that for myself. And so I would just kind of challenge politely people who have power to think about bringing something like the Undoing Racism training to your agency or your organization, to try to go to anti-racist trainings when you can. JBFCS offers a lot of that. I took one of my staff to that in January. You know, Undoing Racism I've been to on a personal level, and I would like to send more staff to that, but what we started doing at our agency is bringing in trainers to address the trauma of racism within the child welfare system, within the mental health system, and that's something that I have to take ownership of. And so I know this isn't exactly a question, so I apologize for that, but I just wanted to bring that up because in this time of movement, you know, racism is an active behavior, so undoing racism is also an active behavior, and we need to all take part in that on an individual and a systemic level. So, yeah.
Hi, good morning. My name is...
Does anyone on the panel want to speak to that before
yes,
we
sorry.
move forward?
Thank you.
Okay.
Hi again. My name is Corinne Vanderdonk, and I am both a fairly new vice chair of the Health and Education Community Board of Community Board 6. I know I've seen Jennifer, and Gail looks familiar to me, and that might have something to do with the fact that as a family, we're very familiar with, how would I write it, with the system because of a child that we have with neurological developmental delays. So I have two questions. One is, what can something, a institution like a community board do to help you with the budget advocacy and help with the people in the front line? I would love to hear more if you want to take my name and number or name and email. If there's rezos, if there's anything that we can do as a community board, that would be great. And then second, I'm actually, I find this redesign and transition sounds fascinating, and I'm wondering if any of you would have staff or a program where you can come and do a presentation on this at the board. Would be great.
So just really quickly, the city produces a local plan. Under the mental hygiene law of the state of New York, the counties have plans that they have to do around where the needs are, where the services are, what families want, what the community needs. And that's a really important process for the community boards to feed into. So I might hand this off to Marnie unexpectedly, but because I don't want to talk about what her department does. But the local plan is a very important document. And particularly having a list of things over a period of years that have been identified by the community, various communities, community boards, families, et cetera, people by disability areas, kind of how it's organized, and comparing what people need versus what has been coming through with resources. So that local plan is a really important document. It's not the only thing, but it's a really great thing for a community board to do.
Yes, so we do have, as Gail said, a local services plan that we do get community input into, and that's a critical piece of it. And so I'd be happy to, connect with you afterwards if you're interested in learning more. And I think that the other thing that, the state, and particularly because you're asking about the Medicaid redesign, right? The state is often putting out, I'm looking at Donna, documents for public input with there's almost no piece of this that hasn't been put out for public input, from the waiver applications they submit up to the federal government to the service definitions. And so really I think the other opportunity here is to ensure that those distribution channels, I think people sort of immersed in the world of children's mental health tend to know how to tap into that, and perhaps a community board may not be even aware of these opportunities for comment. So I think also figuring out how to push that information out to community boards as well, to provide them with the opportunity for that comment, maybe another linkage that we can make. So, but I'd be happy to connect with you after the panel.
Great, thank you.
Hi, I'm Joan Siegel. I'm with Good Shepherd Services, and first of all, I thought this was very interesting, and I have been following this for the last 7 years, and I learned something, so that was awesome. I have actually very practical questions. There's $30 million. Will any of that be allocated to agencies who need startup costs? And how can we advocate for that? I work for a foster care agency. we have to now create an Article 29I clinic that requires, renovation, purchase of items, et cetera, et cetera. So that's a concern for me.
Yep. Yes, there'll be startup available. The trick is, and what we're talking about now, is how do we set up the startup to get federal match, to double it, essentially. Okay. So more to come on that soon.
Fantastic. My second question also, so now the services are all going to go through the health home, right? The spa services are going to be billed through the health home?
No. No, they're not billed through the health home.
Okay.
They're billed, direct between the
provider and the plan. They're going to be billed direct. Okay. All right. Thank you.
Hi, good morning. My name is Carla Beckford, and I'm in the area of assessments, and I have a very specific question with one little backdrop. So I do assessments in Harlem, and there is a huge divide in terms of access to quality assessments. I want to do one caveat before I go to my direct question, and that caveat is this. I know we've talked about using lens of race and class. There is no way that in my training as a human being, parent, provider, that we can separate underserved schools from mental health. I have found no way to do that. I want to piggyback. This is my second time I'm sitting in the audience with Dr. Havens on a panel, and when I first met you at the Schomburg, you said one of the most compelling statements about schools, and so I'm here to kind of bring that up. I see children directly from K all the way up coming from schools and from classrooms that are severely underserved. So my specific question is, and anyone on the panel can speak to this, particularly when we're talking about trauma-based in assessments, treatment, clinical services, and clinical services must start with accurate quality assessments. So my question is, do you believe neuropsych testing, which I have a very difficult time getting for children, coming from traumatized homes and environments, trauma-based assessments for children and adolescents can leverage, do you believe they can leverage their complex needs so we can target their clinical needs more clearly, and what are the funding sources for us in the community when we're trying to get these children neuropsych testing? Okay, so we're looking at the brain-behavior relationship in the context of a traumatized environment.
Good luck.
Yeah. I mean, I think that's a great answer, because the reality is that's one of the things that I often think about when, when a young child, we got audited recently, and there was a young child we put on our high-risk list. Put them on our high-risk list based on what the young child needs were, not maybe what most people would put someone on high risk for in most clinics, because it's not an adult, it's a 3-year-old. And the OMH auditor asked, something to the effect of, well, why didn't you get a psychiatric? Well, the child actually didn't need a psychiatric. What it needed was a developmental evaluation, which is what we were trying to work towards through CPSC. So those are the things in the wrestle of trying to figure out, how do you support, how do you give feedback, how do you push back on different organizations to begin to think more broadly about the spectrum of services that we're all trying to figure out, because that's a great question. So thank you for it.
And the problem we have is that neuropsychological or psychoeducational or whatever you want to call it, which is crucial if a kid's having learning problems, you need to know what they are in order to intervene effectively. Those are considered by health payers educational services, not psychiatric or mental health services. So it's a huge, and it's expensive. I mean, because they have, I don't know why they do this, but they write these 45-page reports. So it's like $5,000, $6,000 to get that on the private side. And what DOE does is completely inadequate, completely. So it's a huge challenge, and underserved and under-resourced schools can make kids worse rather than better. And I don't know what we're going to do about that. I mean, nobody can get neuropsych evaluation except for rich people. And my opinion is the Department of Education
makes a big investment in assessing kids, and doesn't do a very good job.
So, Marnie, you want to?
Sorry, just one thing
more?
to add to, and not speaking directly to your question about the neuropsych evaluation, but just that we, again, through Thrive NYC, have really been making a major investment in addressing the problems that you raised, which is that schools need better capacity to address the mental health needs of their students, and they need it at all three tiers. They need it for all students universally, they need it for students at risk, they need it for students who have an indicated problem, and so, you know, I know we're out of time, I won't get into it, the details, but we've really invested in a really significant expansion of consultation and other types of services to support schools' ability to meet the mental health needs of their kids.
And the Department of Education needs to invest in education for teachers about psychological, psychiatric, and developmental challenges. It shouldn't be just people who are trained to work with special ed who have those skills. It should be everybody.
You guys have been fantastic. You have put in overtime. I thank you for coming. I thank you for sharing your expertise. I thank our really interesting and smart audience. This has been great.